Good evening. I'm Jeffrey Sterling, Surgeon General for Alpha Phi Alpha Fraternity Incorporated. On behalf of our General President, Brother Willis Lonzo III, and the Brothers of Alpha Alpha, I would like to welcome you to the Surgeon General Initiative webinar. Cancer prevention and other discussions around the topic are very near and dear to the Brothers of Alpha Phi Alpha and to the African American community in general. And it just bears mentioning that we have a special relationship with the V Foundation that I'd like to take a second to discuss. For the second year, Alpha Phi Alpha is teaming up with the V Foundation for Cancer Research to raise awareness and funding for the Stewart Memorial Cancer Research Fund. The V Foundation for Cancer Research established the Stewart Memorial Cancer Research Fund in memory of celebrated ESPN sportscaster and V Foundation supporter Stewart Scott after he passed away from cancer on January 4th, 2015. Stewart Scott was a beloved Alpha Phi Alpha brother. His legacy lives on in the Stewart Scott Memorial Cancer Research Fund, which supports the work of underrepresented scientists and researchers developed and dedicated to improving outcomes for minority cancer patients. As many of us know, Stewart inspired millions when he said, "When you die, it does not mean that you lose to cancer. You beat cancer by how you live, why you live, and in the manner in which you live." Here's why it's important. African Americans die from cancer more than any other ethnic group in the United States. Through generous donors, the V Foundation has now invested more than $12.7 million in grants designed to support the work of minority scientists and research that is dedicated to finding therapeutic treatments and positive outcomes for African Americans and other minority populations. Thank you to the V Foundation. With that, I'd like to introduce the moderator for this evening's webinar. Deputy Surgeon General Christopher Womack is the actual Surgeon General Deputy for Healthcare Disparities, and he's perfectly situated to do exactly that. His work is with Johnson & Johnson, in which he is the Director of Real World Value and Evidence Alliance Leadership Oncology. I couldn't be more pleased with the panel that we have assembled and the conversation that we'll have this evening on prostate cancer awareness. And without any further ado, I'd like to introduce you to Brother Dr. Deputy Surgeon General Christopher Womack.
Thank you, Brother Dr. Sterling. I appreciate those comments. First, I'd like to provide a disclaimer for Alpha Phi Alpha Fraternity Incorporated, as well as our panelists. This discussion is for informational purposes and should not take the place of conversation with your healthcare provider. Greetings to all. Thank you for joining us for this very important topic for men in general, but especially for Black men. Our distinguished panel will engage in a discussion focusing on prostate cancer screening. One thing I ask of all of you in the sound of my voice, and I refer to this as something called CAD, C-A-D as an acronym, what means consumption, action, and dissemination. First, you're going to consume information that's going to be presented to you by our panelists. We want you to take action on that information. And just like any treasure that should be shared with others, we want you to disseminate this information to your friends, families, and those who will listen to you regarding the information presented. We have two purposes for this program. The first purpose, save lives. What more plain can that be? The second one came about during a research initiative I was doing, and I spoke to a patient, and one thing that they brought up to me was that they finally figured out, this was a male patient, said, "You matter, I matter." What does that mean? That means you matter to your family, your friends, your spouse, your significant others. And by you feeling that you matter, you need to take ownership in your health and be an active advocate for yourself at times, and also an active advocate for your friends and family. One of the things I want to make sure I present to you are 3 quick facts. I don't want to overwhelm you with a lot of facts and figures, but I just wanted to go over these items. 1, prostate cancer is the second largest cancer killer of men after lung cancer, affecting 1 in 9 men. Number 2, prostate cancer has no symptoms until it progresses. Black men have the highest incidence of prostate cancer and more than twice as likely to die from it compared to Caucasian men. And 3, one of the most important points, if diagnosed early, and I'm going to repeat that again, if diagnosed early, prostate cancer is often curable. So that is very important. So without further ado, what I would like to do is take this opportunity to present our panelists. First one, Dr. Kolmar. Dr. Kolmar is a Spring 93 initiative of Alpha Phi Alpha Omicron Lambda in Pittsburgh, Pennsylvania. Kolmar earned his bachelor's in psychology with a minor in music from Carnegie Mellon University. Kolmar received his doctorate in psychology at the University of Alabama at Birmingham and his master's of public health and epidemiology from the University of Rochester School of Medicine. Dr. Figueroa Mosley has held academic and leadership positions at the Center for Disease Control and Prevention in Atlanta, San Diego State University, the Mayo Clinic, where he was the director of the Office of Community Engagement Research, the University of Rochester Medical Center, and the University of California at Davis. His research is focused on symptom management of cancer patients and the impact physical and social environments have on children and adults. He currently sits on the National Southwest Oncology Group Board Committee, examining and impacting the diversity of women, Blacks, Latinos, Asians, and others underserved communities in research and cancer clinical trials. Reverend Dr. Liddell Letzum is a board-certified general surgeon with a background of study in Christian and medical ethics. He received his bachelor's degree in psychology and pre-medical sciences from Columbia University. From there, he earned his MD at Jefferson Medical College in Philadelphia, PA, a fellow of the American College of Surgeons. He is currently the clinical director for quality wound care in Hawthorne, New Jersey. Dr. Letzum has traveled the world providing free medical and surgical care with various missionary groups. In addition, as a proud member of Alpha Phi Alpha Fraternity, he participates in several local community and service endeavors. He is also the founding director of Vandenberg Health Equity Project and a faith consult for the COVID-19 Prevention Network. Retired Colonel James E. Williams, Jr., a prostate cancer survivor diagnosed in 1991, has been active as an advocate for more than 29 years. He was a human resource administrator for 15 years after retiring from the Army. He is a senior professional in health resources. He is the principal of Jim Williams and Associates, a consulting firm specializing in prostate cancer awareness, education, and advocacy. Colonel Williams is a board chairman of the Pennsylvania Prostate Cancer Coalition and past chair of the Intercultural Cancer Council at Baylor's College of Medicine and the University of Houston. He has appeared on NBC's Weekend Today program and was featured in Good Housekeeping, Cure, Prevention, Mail Call, and other magazines and newsletters speaking on the topic of prostate cancer awareness and advocacy. And finally, Dr. Victor J. Narcisse practices at Houston Methodist Hospital in Houston, Texas, as the Associate Division Head of Hospital Medicine, Houston Methodist Physicians Organization, as well as the Director of Clinical Research in the Division of Hospital Medicine. Dr. Narcisse was a graduate of Tulane University and completed his medical training at Baylor College of Medicine. One interesting thing as we've gone through our panelists, and we wanted to do this a little different as opposed to just having a general Q&A, that personal story that motivates others to get them to understand that that could be you or your family member or someone else is important. So with that, I've asked Colonel Williams to present his personal story. Brother Williams, you have the floor.
Thank you, Brother Womack. Good evening, brothers. This is my story. I was working as a human resources director at the American Bar Association in Chicago in 1991. My wife said I needed to go see our family physician. I argued that no, that wasn't necessary. I was a private pilot. I had to get a physical every 3 years from a flight surgeon to maintain my pilot license. I'm running 5Ks. I'm in the best of health. There's really no necessary to do that. Well, my wife, and you know how wives are, said, well, the children are going to this doctor. I'm going to the doctor. I think you should go to the doctor. He's a good guy, and I think it would be in the family's best interest. Well, I went to the local doctor and found out that he was a very good internist. He introduced in this examination in the blood work something called a PSA. This is 1991, and this was a new test. Well, the results of that PSA was that I had a high number. Back in 1991, 4 was the norm for PSA testing. And if your number was under 4, you were okay. And if your number was over 4, it was suspect and probably would call for you to see a specialist. And that's what happened to me. I was referred to a local urologist who took a biopsy. And when the pathology report came back, it found out that I did have cancer. And they're able to grade these cancers. And my Gleason score was 7. Gleason runs to a total to 10, and mine was 7. Well, being diagnosed with prostate cancer, what was the next step? My urologist said, now listen, I look at the world differently than a radiologist and oncologist. And so I want you to get a second opinion from these specialists. In addition, I want you to go to Mayo Clinic up in Rochester, Minnesota, because they're doing a lot of surgery up there, and there's a specialist surgeon I want you to talk to. Now, I'm living in the Chicago area. There's fine hospitals in the Chicago area. But I took his advice and took the 5-hour trip to Mayo Clinic in Rochester after seeing a radiologist and seeing an oncologist in the local area, took all that paperwork to Mayo Clinic. When I got to Mayo Clinic, I fell in love with the place, with the staff and the way it was organized. They reviewed my paperwork. I had an interview with a surgeon, and I decided to have surgery at Mayo Clinic. Now, I knew I was at the right place because right next door to me in the hospital was a sheik from the Middle East. He had his private 747 parked at Rochester Airport. He had taken over the top floor of the Ramada Inn for his staff. He had a bodyguard right outside the door in the hospital. So I knew it was good enough for the sheik. It sure was good enough for Jim Williams. Well, the surgery was performed on the 27th of September in 1991. And as a result of the surgery, and of course now having removed the gland, they could have a better understanding of what was going on. And the pathology report came back that I had an aggressive grade stage 2 prostate cancer. The surgeon noted that he did not find anything in the lymph nodes, did not find anything in what they call the prostate bed, but I had positive margins. And he said there might be some microscopic cancer that we didn't see. And so I suggested you go on a second procedure, hormonotherapy, which was Lupon, which is a drug which suppresses the male testosterone, which is the male hormone. And we know that testosterone suppresses or carries prostate cells. So I had what they would consider adjuvant therapy. I had not only surgery, but I also went on a hormonal therapy for 6 months. And I've been cancer-free for almost 31 years. Let me quickly review some of the points of my journey. First, I had a wife who saved my life, who insisted that I go see the family doctor when I thought I was completely well and had no problems. Remember that prostate cancer is a silent killer. And it's in its early stages, and many cancers are like this. In its early stages, there's absolutely no early warning signs. And that's why you need to go to the doctor when you're well, not when you're sick. I would have probably lived about 5 more years, and then I would have had serious problems, if not before that time. And I try to make this point to the men I talk to because they say, hey, I'm fine, I'm not having any problems. And I have to remind them that, this is the time to go to the doctor when you're well. We'll be talking about that more later. I had a family doctor who was on top of his game and was included this new test called PSA, which is not perfect, but it pointed out that something was going on and we needed to focus our attentions on that part of my body. And in medicine, many times we have a problem because of the silo effect. You go to one specialist and he or she says, well, this is the way to go. And there might be some other options available to you that you're not aware of. And my urologist wanted me to see all the options that were available so that I could make a decision. I went to a world-class hospital, Mayo Clinic, and I had one of the best prostate surgeons in the country operate on me. And in addition, not only did I have that surgery, but they suggested I go to another procedure. And last but not least, I have a healthcare program because I'm retired military called TRICARE for Life, which took care of most of the expenses. So this is a perfect storm for me. And I contend that every American should have, if they have to go down this road, should have the same experience that I've had. And that hasn't been the case. And that's my story, Brother Womack.
Thank you very much for that personal testimony, Brother Colonel Williams. And I think it's very important that everyone understand those personal stories, that could be any one of us. And at some point, it will be one of us, as Brother Colonel Williams has talked about his journey. And this comes to our section when we just start having a Q&A discussion. And it was one thing that was important that brought up during Brother Colonel Williams' journey, and I hear from other men as well, is that some men don't know what the prostate is and what role it plays in men's health. And that's very important to know. So, Brother Dr. Narcisse, can you guide us with that information? Sorry, brother, you're on mute.
Sure. Thanks so much. We have a picture, I think, that may be helpful as well. Prostate's a small organ. It sits between the penis and the bladder, and normally it's about the size of a ping pong ball. Weighs about 1 ounce. And you can see that the bladder actually releases its urine normally through an opening in the middle of the prostate. As it exits the body, goes through the penis and the urethra. So that's where it normally sits. But as most of us know, as we get older, we start to have more and more problems with it. The prostate gets larger, and you can see from this location that as the prostate gets larger, it will squeeze off the urinary tube. So the prostate, as we get older, will start to block the normal release of urine, and it'll be more difficult to urinate, to have the urine leave the body, and occasionally it will cause trouble where the urine is difficult to start or difficult to stop the urinary stream. This is very, very common as we get older. Eventually, it can get to a point where it's blocking the urine release almost totally, and it can cause infections in the bladder to occur. So that's a typical thing that you'll see, but the normal function of the prostate is to help release a fluid that is important for semen. The prostate puts out about 30% of the fluid that makes up the semen volume, and it counteracts some of the acid-base conditions that the sperm are in when they're first created, and allows them to live all the way through to their destination. So that's an important part. Additionally, the prostate's important as a release of hormones. There's a hormone that we all know is testosterone that is converted into its active form inside the prostate. So that's an important function. The last thing that it does routinely is that when you're having an ejaculation, the prostate closes off the urethra so that urine doesn't come out.
Thank you for that information, Brother Dr. Narcisse. And actually, before I go any further as well, for our viewers, if you have questions or thoughts, please feel free to enter them in the comment section of what you're viewing. Brother Dr. Narcisse, that was some interesting information. And I guess the next question is, can I exist without a prostate? And what happens if I don't have that prostate anymore?
Absolutely. The prostate is not a critical part of life. You can live without the prostate. You can have an orgasm without a prostate. But it is important. And if the prostate's removed surgically, there are a number of side effects that happen commonly. The one that we talk about the most is impotence. So men will have a difficulty achieving and maintaining an erection. A lot will depend on what occurred during the surgery. There are newer surgical techniques that are nerve sparing. So the chances of having impotence are much less than they were in the past, but they're still there. And it's something that's important to recognize. There are techniques of adjusting to life after the prostate's removed, if it needed to be removed for cancer, but it certainly you can achieve an orgasm and you can live. The other issue that is very, very common is incontinence. As you can see from the picture that we showed before, the prostate is right in between the bladder and the penile shaft. And so when you surgically remove or otherwise alter the prostate, it's very common for the valve functions that keep the urine in the bladder when it's supposed to be there and releases the urine from the bladder when it's not, can become disturbed. And so urinary incontinence is something that can occur.
Thank you for that information. And Brother Colonel Williams, you brought up some interesting information regarding your personal story itself. And my question for you is, what are those risk factors for prostate cancer? And also from those risk factors, what are those that are controllable versus those that are not controllable?
Well, age is one of the major risk factors. In the past, prostate cancer was considered an old man's disease because we find that older men are more likely to get the disease than younger men. However, in recent studies, we find that younger and younger men are getting prostate cancer. And so we're encouraging men at an earlier age than 65 to be screened, especially African-American men or those who have a family history. And that's the second risk factor. If you have a brother or father or another male within your immediate family who's had prostate cancer, then you are at higher risk for the disease. In my family, for instance, I've had prostate cancer. My brother-in-law also had prostate cancer. So my two sons are getting it from both sides of the family. And they started testing as early as 40 just to stay on top of the numbers. Race, unfortunately, is also a factor. And we find that African-American men have a higher rate of prostate cancer than their Caucasian contemporaries. We're not sure why that is so, but it is a fact and it should be considered. Obesity is another risk factor. And whether we're talking about prostate cancer or your health in general, obesity always causes men to have problems, not only with their prostate, but other parts of their bodies. And so obesity is a risk factor. And diet is also something that we all are aware of, but we need to do a better job of practicing that. And we know it has an effect on the body because as we look at our Japanese brothers living in Japan, they have a less of a meat diet and more of a soy and vegetable diet, and their prostate rate is low. But as Japanese men have migrated eastward to the United States and pick up Western habits and Western food habits, we find that the Japanese Americans rate is much higher than their counterparts in Japan. So diet is always a function, and then lifestyle. And I just want to bring out one point here is risk, and that because of the stress factors. And as an African-American man, I don't have to tell you the stress that you have to go through. And these factors are something that considered in prostate cancer: your age, your race, obesity, diet, and lifestyle. Now, when we talk about symptoms of prostate cancer, this is something that's very important because we're talking about quality of life issues that many men don't talk about. Men my age who are retired find themselves having these quality of life issues, and they suck it up and they keep it to themselves. The previous brother talked about BPH and the enlargement of the prostate and what that might result in. But the symptoms that we find in advanced prostate cancer are the same as they might be with enlarged prostate. And so that's why we need to go to the doctor and have examinations so we can distinguish whether the problems that you might have or the symptoms that you now have might not be cancers or might be cancers. And as was mentioned earlier, urination becomes a problem. Split streams, the slow or weak urination. Blood in the urine might be a problem. Trouble getting an erection might be a problem. Pain in your hips. And men that I talk to, when they really get down to it, 90% of the men in their lifetime had some problem with their prostate. And they need to make sure that they are as sensitive to their prostate as women are to their breasts because of these problems. And these signs and symptoms are not always cancer, but we need to distinguish them and get on top of the problem early on. Brother Womack?
Yeah. Thank you for that, Brother Williams. And it's very interesting. As African-American men, we do have that tendency to suffer from John Henryism, meaning that, okay, today's Monday, I'm hurting, but if I take an aspirin Tuesday, it'll go away. So that should go to show you that we need to go to our physician to have these discussions in detail. Dr. Lessem, I'm going to do a little twist on you because I see some questions coming in the box, but I'm going to address that question and then filter in some of those questions that actually tie to this. And the question is, what are the screening tests for prostate cancer, and at what age should I begin having those screening tests?
Brother Chris, thank you. One of the things I want to touch on before getting into the actual screening test is just even talking a little bit more about the risk factors, and as Brother Colonel Womack just talked about, the diet is really interesting in the sense that the American diet in particular of eating processed meats and saturated fats, it's been shown that those things really alter the prostate's metabolism. So it's not just being American, but it's also, for a certain extent, how do we eat as African Americans or people of color? And then an interesting thing about it also found with prostate is our circadian rhythm. So pilots, people who have shift work, people who have jobs where your sleep cycle, where you don't have a steady schedule and you're constantly sleeping on different schedules, that has been shown to actually carry a risk for prostate cancer. And then there are things that talk about in terms of, you said, action, how we decrease our risk: not smoking and avoiding secondhand smoke, maintaining a proper weight, eating fruits and vegetables every day, and fruits and vegetables that are less processed and don't have a bunch of salt in them. And then the common one that we all tend to overlook, as we talked about, paying attention to our prostate. So actually getting screened. And if you're an African American man, Brother Chris, you said it well, we need to start thinking of ourselves that we matter, and that we matter to our community in more ways than just money and sex. We matter. And if we're male of color, we're at risk. And there's a lot of this talk in the community that prostate cancer doesn't really kill, and that there's a whole lot of autopsies that show that people have prostate cancer and they're fine. And I always think, well, what people are you talking about? Because if you're brown and your prostate is not doing well, chances are it's going to shorten your lifespan in some uncomfortable way. So you want to be prostate sensitive and screening sensitive. And the recommendations are out there in terms of they generally want you to be screened by the time you're 60. But if you're an African American male, you're already at a higher risk. So you want to be talking to your doctor about your prostate risk in your 40s. And there's something out there known as the baseline. So the Memorial Sloan Cancer Center, the Johns Hopkins Medical Center, all of them recommend, and even MD Anderson, that you should have a baseline PSA, which is a prostate-specific antigen test, somewhere between 40 and 45. It doesn't mean you're going to get it every year after that. But if you're an African American male, you're in a risk community, so your doctor should be talking to you, or you want to talk to your doctor or your clinician about getting that blood test done somewhere between the age of 40 and 45. If your father, your brother, any first-degree relative in terms of a cousin had prostate cancer, the general recommendation is usually you want to be screened at least 10 years earlier than when they were screened. But if you don't even know that age, once again, it goes back to 40 to 45, you want to at least get a baseline PSA. And as specific as the PSA is, the next step is actually doing what is called a digital rectal exam, and the doctor putting their finger in our anus and checking the contour of our prostate. Because the PSA, as sensitive as it is, it doesn't always mean that you're going to have an elevated PSA. And that's one of the frustrating things about prostate cancer, is that, as the colonel said, his PSA was only 9. That's not a horrific number. It's a glaring number, but it's not a horrific number. He had surgery, he had follow-up, and he still had positive margins. So you want to make sure that you are having these conversations with your doctor in the sense of, I want to get the PSA. I want to know what my PSA level is. The ideal PSA level is less than 3, and even more so, preferably less than 2. And I want the doctor to do the finger sweep of my prostate. Do not be afraid of the finger. It's not a sexual activity. It's a life-saving activity. So you just want to reframe your mind as, I matter. I'm at risk, and I need to make sure I'm doing the things to keep myself at risk. And the 2 big things to screen for prostate cancer, once again, is the PSA level. You want to have that done at least 1 time between 40 and 45. And you also want to get a finger sweep of your prostate done somewhere between ages of 40 and 45.
Thank you for that information. And it's very interesting as you talk about the testing with the PSA and the DRE itself. I guess the question to you, Brother Dr. Letzum, should I make an option to do one or the other when I go to my physician, or should they always be done together?
In the same setting, I wouldn't say you have to get them done in the very same setting, but you want to get them somewhere in the same time period, and preferably to get them done right then and there. And if you're thinking about it, do it then. Life is busy, life is hectic, you are prone to forget. Get the finger sweep, get the blood draw done right then and there, as opposed to waiting 3-6 months to try and figure out to do it again. So my initial recommendation would be, yes, try to do it in one setting, but it's not a mandatory thing. And we'll get into it again later on, but you have to understand, with cancers, almost everything is recommendations, and the recommendations vary, but I push my patients and my family members to lean on what Memorial Sloan Kettering and Johns Hopkins recommend, that you should be getting some awareness of what your prostate is doing between ages 40 and 45.
Okay. No, thank you for that information. And as we're talking about numbers himself, and Brother Colonel Williams talked about his number for his PSA. And I guess I pose this question to you, Brother Dr. Narcisse, is we hear the term numbers and PSA. I guess the question, what do we mean by what is a good number? And are we looking at that number at that point in time, or are we looking at it based upon a trend, saying that the numbers are trending up, that we should be alerted?
So, excellent question. So the standard number that we use is 4. I think you'll hear that pretty consistently, but if you just do it one time, that number doesn't really give us all the information we would like to have. If you look at your PSA over time and with repeated testing, I think that it really adds a lot of information to your understanding of your prostate cancer risk. So I think that you've heard already that it's important to get the baseline. 40, 45 is what I usually recommend for African American men. I think that that's very, very, very important. And then follow your PSA over time. It's usually checked about every 2 years, and but don't be afraid if it goes up a little bit. It's actually normal for the PSA to increase over time. And actually, patients will sometimes get to a place when you're 70, 75 years old that we actually won't check the PSA anymore. So I think that there's an age-specific PSA, and your doctor can kind of go over that with you based on the age range that you're in. But I think that it's very, very important to get the PSA checked. We usually recommend about every 2 years for the blood test.
Thank you for that information. And what I always find interesting is that, as men and I've been in barbershops where I've seen guys shown where their Achilles have been torn, the surgery was done. They could describe everything to the scalpel that was used to take it out, broken leg or things of that nature. But there tends to be some type of psychological barrier that men deal with, especially African American men, that prevent them from having prostate cancer screening. Brother Dr. Figueroa, can you go into that and explain that barrier a bit for us?
So the barriers fall into basically what I would say a lack of knowledge, and then their perceptions, attitudes, and beliefs. And so for a lot of people, not knowing anything about prostate cancer may stop them. They may even have not know what the screening methods are, and that for programs like we have now, people are beginning to have an understanding that DREs, digital rectal exams, and the PSA test is very important in terms of understanding our prostate and screening for our prostate. Also, a lot of people don't know when and where to go for screening. And that is very important, and that you have this conversation with your healthcare provider, especially when you're at increased risk for prostate cancer. Like it has been previously mentioned, if you have a family familial risk, it's between 40 and 45. But even if you've had somebody that's even closer, you may even screen 10 years earlier. In terms of perceptions, attitudes, and beliefs about prostate cancer screening, there is sometimes people have a fatalistic or rather just not know about their cancer status. And what I hear out in the community many times is that the awareness of prostate cancer does not prevent cancer. And so people will think that if they just ignore it, that cancer will just go away. There's also the thought about the fear of screening is painful, and that, as it's been spoken before, the screening test is a lifesaver, not a sexual issue or concern. And it's interesting that there is currently a belief amongst young people in their 20s, 30s, and 40s that they don't need to screen, and that when we learn about the importance of the screening, because the average age of African Americans typically screening is around 66 years of age, and it's important to understand all that. There's also the stigma associated with cancer, and then many people may refer to religious beliefs. I guess one of the interesting studies that we did at Mayo Clinic was that we were able to recruit Muslim men to participate in a prostate cancer screening and colorectal screening study, and we're able to work with the imams to get them on board in terms of understanding what the process is. So so basically it boils down to lack of knowledge and their perceptions, attitudes, and beliefs about diagnosis and screening.
But you bring up a very interesting point, and again, I know it ties into John Henryism and also to the point of not knowing means I'm safe in some forms of fashion from someone's mind versus the possibility of knowing and what is up next. So I know that becomes a panic with many men.
If I could chime in one time.
Sure, go right ahead.
One of the things I want to follow up on with Dr. Colmar is that I remember in the 90s, as Colonel Williams alluded to, prostate surgery was this really big life-altering thing. And this thing of what am I going to be able to do as a man after prostate surgery? How am I going to be able to just function was a real question. And thankfully, here we are in 2021. The surgery, the treatments, the modalities, which will be brought up in a more detail in a different time, they're much less life-altering. And I just want to make that clear to the brothers in the audience that not only do you not need to fear a finger being inside of you, there's a lot less to fear about in terms of what will they do to me if I am the person who has prostate cancer.
And I leave the floor open to any brothers who have any other comments to add to that.
So, Brother Romack, we're talking about a mindset here. Men take better care of their cars than they take care of their bodies. The cars are taken in to have maintenance, change oil, have inspections, etc., because we know that it extends the longevity of the car and cuts down costs. And we need to have the same attitude about preventive medicine and why these screening tools are important. Now, there's been a lot of controversy about the PSA because it has high false positives and has high false negatives. But all screening tools have this feature. It's not unique to prostate cancer. And the baseline numbers that we've talked about is so important because, as I said, in the early stages, when you can get ahead of this disease, normally there's not any early warning signs, like thick-headed Jim Williams here, whose wife had to save his life. And so comparing these numbers from time to time will give the internist or whoever's looking at you some idea of what's going on. You remember, because of our healthcare system, the patient and the practitioner don't have too much time together. The system causes us to push people through the system. So these screening tools are good, and these numbers are comparison are good because it tells the physician in that limited time that they have to be with you that maybe this visit, or maybe we need to concentrate on this part of the body because I see the influx of numbers going on. So preventive medicine is so very, very important.
Yeah. Now that was a very key point. And actually going more into the medicine topic, especially as we look at the insurance plans and how denials are submitted and some preventive services are not allowed. So if any of the viewers or myself, when we go to our doctor and the doctor does not require a prostate screening, even if I fit the profile, saying if I had a father with prostate cancer, maybe I'm a smoker, not a satisfiable diet, things of that nature, what can I say or do in that conversation? Because sometimes as men, especially as Black men, when we go in that doctor's office, we get real quiet. We want to get in and out like Jiffy Lube. So what is it can we say to that physician to say, I need to have this test? So what I want to do is, I think I was going to start over with Brother Letzum on that question. And if anybody else wants to chime in, that'll be a great question as well.
Sure. I think one of the things you have to remember when you're in a doctor's office, that it's your time. It's about you. It's not about the doctor. It's about you and making sure that you leave with a better sense of who you are and how healthy you are. And so don't be too shy, but also please don't be too combative. And if you haven't heard from the general tone of this conversation, as African-American men, we matter and we're at risk. So we really want you to be proactive with your conversation and say, hey, doc, I'm a Black male. I'm a biracial male. I'm a Latino male. Where do I stand with this? And then also, as you go through this in terms of dissemination, start having conversations with your family members. No, does my cousin, does my dad, does my stepfather, who in my family may have prostate cancer. And after that, saying, I would like to at least have a baseline. And if the doctor doesn't seem to be getting that, it is your right and your responsibility, quite frankly, is find out why. Say, can you just explain to me from your medical opinion why you don't think my having a baseline awareness of my prostate at this age is not important? And unless they give you an answer that makes some sense, then you have two lines to go, two options, I say. One, ask for a second opinion. You always can ask for a second opinion. But the other thing, which I encourage people to always remember, when a doctor is saying something that doesn't jive or is congruent with what you're expecting to hear, find a polite way to say, doctor, thank you for your answer. Would you mind documenting in the note our conversation? That I asked for this, you didn't think it was necessary, and the reasons why. You have a right to keep your clinician accountable. You don't have a right to attack us, but you do have a right to make sure that we're clear in our thinking regarding you, not that we're clear in our thinking regarding how fast we have to get to the OR or how fast we have to get into the next room to talk to the other patient. I hope that helps.
Now, thank you for that, Dr. Letsom. I have another question, and then I want to go over to some of the comments in the box itself. And this is to Brother Dr. Figueroa. I'm gonna use the term black man, because if I say African American men, Caribbean men and Latino men seem to think they're out the mix. No, you're in this mix as well. So it should be black men in general. But I'm a black man. I'm trying to find more information to improve my knowledge regarding prostate cancer screening, as well as bringing that information to family members. Any suggestions on places or recommendations I can go to that'll present it not in a heavy scientific format?
Yes. First of all, attending meetings like this is a very important way of actually being able to gain that sort of knowledge. Speaking with your healthcare provider about prostate cancer, most healthcare providers will be able to gather you information about it, also talk to you about it. You can talk to the healthcare provider about some of the risk factors that you or your family members have had. I think it's important to have an advocate, family members that are advocates, just as it was with Brother Williams, where it was his wife that was the greatest advocate and was probably the person that saved his life. Studies have shown that family members are the strongest source for screening for prostate cancer. In terms of prostate cancer screening sites, we've had a few scroll across the bottom of our screen, the zerocancer.org, also Prostate Cancer Foundation, PCF.org, us2.org, and as well as the Centers for Disease Control prostate cancer site, which basically goes into the issues around prostate cancer screening, and is a very important resource for brothers to understand prostate cancer much better.
Well, thank you for that response. And at this point now, what I want to do, I guess I call it a free-for-all, where I want to throw out a question that came up in the comment section, and I'm trying to pull some of them out. And actually, for our viewers, we're going to have an overtime session as well, and our panelists will hang in as long as possible to address some of these questions. But one that came up was very interesting. The question was, how can I lower my PSA? Is the PSA what it is, or is there something I can do to lower it? So anyone want to raise a hand? I'll call them first, and then I'll move along the screen.
Como, you're going to go? I have come across nothing that reliably is going to say control or lower your PSA. And one of the things, as Brother Dr. Narcisse reminded us, the PSA of itself, as we've learned over the years, it's sort of a continuum. So we never want you to look at it as a one-time number. It's a continuum of numbers. Now, yes, there are numbers that we will know for a certain age range is out of whack and we need to do more intervention and screening. but it's not a one-time number. It's a broader picture. And that's why we want you to get your PSA, we want you to get your digital rectal exam, and we want you to do it more than once, because that gives us a better picture of actually what's going on with you.
Brother Womack?
Sure, go ahead, Brother Dr. Narcisse, go ahead, and then Brother Williams.
Yeah, there are actually some times when you shouldn't get a PSA. If you're having an infection in your urinary system, that may artificially elevate your PSA number in your blood. If you've recently had surgery or some kind of a procedure, including a prostate, those are the things that can sometimes artificially elevate the number. And there are also certain medicines that we give to patients that have urinary symptoms, such as finasteride, that can sometimes artificially, although that would be more of a longer term process, affect the PSA. So there aren't great ways to lower your PSA by changing your diet or exercise or something along those lines. Okay.
And Brother Williams, what I want you to do is close this out, and then I'm going to turn it over to Brother Sterling.
Yeah, just a quick point that the PSA is produced by the prostate. So everybody has a PSA number. It's not the PSA in itself that causes the problem. What might cause the problem is that when we see excessive numbers, or using the baseline criteria, the number goes from 1 point and then within 3/4 of a year or a year, it doubles. So just because you have PSA doesn't mean you have cancer or that you're producing cancer cells. It's a normal function of the prostate to produce this protein PSA. But it's looking at the excessive numbers that give us an indication that something might be going on.
Yeah, thank you for that information. And you know what? I wanted to do one more question and then move to Brother Dr. Sterling to sort of close us out, and then move to our extended section. What are your thoughts on the use of testosterone enhancing vitamins in men and its impact on the PSA? You all see the big hurt taking it on the commercial. So we tend to think off the shelf, very safe, but can that impact your PSA as well? And I'll start with you, Brother Letson, if you want to take it, then move on over to Brother Figueroa.
Brothers, I have a real bias against pretty much all of the on-the-shelf vitamins and everything else, or supplements out there. And the reason being is because it's completely unregulated, non-supervised, non-FDA monitored market. It's a multi-billion-dollar industry, but pretty much all of those things could be sawdust for all you know. There's nobody regulating them. There's no one monitoring how they're really made. There's no one backing up or making sure that the marketing is real. I forget, the one was Enzyte or whatever. If someone finally tested, found out it was nothing, vitamin water, is because, without being too political, Senator Orrin Hatch, more than, I think about 15 years ago, pushed a law through where none of these supplements have to adhere to any FDA regulation or screening. So I would not bet my life on anything that's considered to be a dietary herbal supplement of any kind. And I just gave my logic why. I don't think of them as actual medical interventions. They are just things that people come up with and market. And there you go from there.
Thank you, Brother Letson. And our panelists, I know Brother Figueroa is ready to jump on this one, but we're going to continue with this. But I want to give Brother Sterling an opportunity to provide out any closing comments. And then, like I said, we're going to continue on the discussion, and it goes straight to you, Brother Figueroa, when we go to that question.
Well, first of all, excellent discussion, gentlemen, brothers. You went through a lot, and there's still more to get to. I want to welcome the audience to Overtime. And the purpose of the Overtime session really is to distill down the information that you have heard in this webinar. We want to make sure that you are empowered and have some take-home messages that really increase your level of knowledge about the subject matter that's been presented to you. I actually want to begin with my own comments on the last question that was asked, because I think that it's an excellent question, but I just want to tweak it a little bit. when you're asking questions about PSA levels, it really begs the notion of what we've been discussing this evening. A conversation about screening is just that. A screening exam is something that points the way forward in terms of evaluating you and your risk and any presence for cancer. It is not determinative. It is only a correlation. So chasing PSA numbers, as was mentioned, isn't something that you necessarily do. So I would actually love to have heard the question of, instead of how do you lower your PSA levels, how do you lower your risk for cancer? And there are answers to that question that I'm going to invite the audience to get into. But as these things go, every time we talk about health prevention, the answers tend to be kind of the same. So for example, choose a healthy diet. It really is just that fundamental. If you're choosing a low-fat diet, staying away from the processed stuff, you're going to be okay, all things being equal. If you increase the amounts of fruits and vegetables that you're eating every day, that's going to make you more healthy in general, and it's going to lower your risk for prostate cancer in general. Your activity is very important. If you are exercising most days of the week, studies show that that is also going to lower your prostate cancer risk. So the good news is that I don't have to send you toward any tropical or esoteric type fruits or new yoga stretches to improve your lot in life. If you just take care of some of the fundamental ways in which you know you should be doing to promote health, you'll have a better quality and a better longevity of life and lower your risk in this example. So what I want to do next is really to distill down the topics that have been discussed. I want you to understand why this topic was chosen and why it's important. It's all been said, but I'm going to give you some very simple talking points. First of all, prostate cancer is the second leading cause of cancer death in men. Hard stop. It's very important. And as the point has been made, we should be viewing it very much in the same way that women view breast cancer. It is just that pervasive. African Americans, and particularly blacks, should really be worried about this, because this is a healthcare disparities forum. We have disparities in the presence of prostate cancer. We are affected more compared to other members of the general population. Part of the reason for that, point number 3, is because of the traditional homophobia and some of the difficulties that we have in accessing care, particularly screening modalities, may lead to us getting screening later than the regular population and thus being diagnosed later than the population. And if you're being screened and diagnosed later, that means that the disease may be more advanced and the opportunity for a full cure may be lessened. So screening, early detection, early treatment are critical parts of this conversation. To that end, if you get screened and detected earlier, your outcome really can be pretty phenomenal. It is such a joy to have our brother Colonel with us today. And as he said, he's been 31 years cancer-free. That is the message here. Early detection isn't a boogeyman about which you should be afraid. It is the path forward to living a longer and healthier life. Please take those points with you. This conversation today was really about screening. We're going to continue later in the month. The last Thursday of the month, we'll be talking about prostate cancer treatment options. We want you to come back for that. But in the meantime, what I want to do in returning back to the full panel now is to just ask you gentlemen a couple of questions, and just to, again, answer these questions with take-home messages for the audience in mind. Are there any nuances that you would like to add to the general comments that I made about things that can be done to prevent cancer? We've talked a lot about screening, but let's just talk about what the audience at home can actually do to lower their risk of developing prostate cancer, regardless of what any PSA or other screening tests may show.
Yeah, this is Victor Nurses. That we heard a lot about diet, and I think that there's a lot of evidence that diets that are high in animal fat and low in vegetables may increase one's risk of prostate cancer. So I think that I'm from New Orleans, and I love my great food there, and all the things that I like to eat are problematic for me. But I think if one is diligent about the diet, I think that that's one of the first steps that you can make.
Thank you. Any other comments on that question? If not, we will move on.
I would add to it. Sorry. I would add to it, even though it's generally known in public, smoking and also vaping. Just vaping is not a smoking improvement. So smoking and tobacco products really damage several tissue types in our body. And then sleep. Whether you are the type A hard worker or the all-night video game person, uh, a disruptive, less than 7 to 8 hour sleep pattern is not great for your overall health, not just mentally, but even in terms of cancer. So paying attention to smoke and tobacco products in your environment and how well you sleep is really preventive medicine for yourself.
Very good. I want you guys, I'm going to pin you guys down on this one, and I want a definitive answer because this is what is being asked by the audience. Take two scenarios, one in which there's a family risk or family history, I should say, of prostate cancer, and one in which there is not. For Black men, when should that first evaluation, whether it's a digital exam or a PSA screening, when should those conversations be had with a primary care provider?
I can answer that. 40 to 45 is really the time when African American men should start to pay attention. The target PSA, there's been a lot of conversation around that, is lower when you first begin your screening process. 4 is the cutoff for all men, but it's a lower number that one would expect when you're a little bit younger. So I think that it's really important to start that process then, and as we've been discussing, follow the PSA over time and understand your personal PSA trajectory.
Everyone agrees with that assessment? I want to tackle this head on because this is something that we all know exists, but we don't talk about. So let's take it head on. Can we talk about the actual role of the digital rectal exam? Why we don't have to fear it, why it may be needed, and what brothers should expect if and when that's being done?
Well, let this layman talk about rectal dysfunction. I talked to a lot of men about this area, and of course, they will say the reason that they're so hesitant with the screening and treatment, et cetera, is because of erectile dysfunction. First of all, I tell them dead men don't get erections, so they need to consider that. Secondly, that there's more than 20 million men in America who have erectile dysfunction problems, and it's not because of prostate cancer. As the body ages, these functions, as other functions, the body decreases a lot. And then the last and a point I want to make, and we don't have time to discuss it here, is what is all this about erectile dysfunction and sex about? To many men, that whole phenomena is a mechanical process. You think about something in your head that sends a signal to a nerve function that, and the nerve function expands the blood in your, expands the veins in your penis, and blood rushes in, and you get an erection. And is that love? Is that always necessary? Is there other ways to please your partner and to please yourself on the sexual plane with this without full erections? So I think it's many times overplayed. We don't talk enough about it. I'm glad you brought the subject up this evening. We need to have further discussions about this whole area about erectile dysfunction, whether we're talking about prostate cancer or something else.
And to follow up on the DRE, one of the things with it, to your question, Brother Surgeon General, is that, so let's say you're the 45-year-old male and you're getting your baseline PSA and it comes back at 5. That's a really iffy number. Even though you'd hope it'd be 3, 5 could be there for any reason. In just infection, you could start to be having BPH, but your doctor or clinician can then do the digital rectal exam, and what that helps is just examining the contour of the prostate. If there's a smooth, decent sized prostate, that gives them a different picture, particularly if you don't have any other risk factors. If they feel your prostate and there's some nodules in there, or it's bigger than they would expect, which also I have to put in there to the audience, it's a fair question to ask your provider before they do the digital rectal exam how much experience they have with it. It's just like a clinical breast exam. It takes a certain level of experience and frequency. So that is don't mean to put them on the spot, but you want to know before they do it, is this something they do regularly so they can have the sensitivity to detect a nodularity or irregularity. But that DRE helps give context to the number. And as you build up a relationship with your provider, hopefully it's the same provider doing these PSAs and exams, they can also begin to sense and say, well, the last time we did this, your prostate didn't feel this way. There's a difference. So that's why you want to do it. It helps give more information and a better context to the numbers.
Outstanding. Thank you. You brought up the points that I wanted to have elicited, so I thank you for that. The final question I have before I allow each of you to give a closing comment really is a tease to the second session, but has relevance for what's been discussed here. I believe two of you actually teased this comment, so let's throw it out there again. You mentioned that there were reasons why a PSA may not be done. I just want that to be reiterated for the audience, because too often when we don't have tests done, we view that as a sign of discrimination or something other than what it may be in this particular example. So I'd like for you just to briefly speak to an example or two why a PSA may not be done after it's been done time and again, or even at the beginning of a process.
Yeah, there are a couple of things that we always look at. Again, the typical screening frequency is about every 2 years. Some individuals who are lower risk will benefit from every 4-year screening. But if you just recently had an infection, particularly if you've had an infection in your prostate, it may be a time to wait 6 or 8 weeks before checking the PSA. Additionally, if you've had any procedures involving the urinary system, it's a good time to wait. And again, remembering that there's a relationship between the PSA and certain medications that we frequently give to individuals for benign prostatic hypertrophy, BPH, or enlargement of the prostate. That would be if you've recently started those medicines, that would be another time to consider waiting. And the person who should make the decision of when to do the test would be a joint decision with your physician, but you really should lean heavily on your physician. You should be an advocate for your first test. And then if your physician says, let's wait for a couple of weeks, that may be appropriate.
Fantastic. I say all the time, we want you to be better stewards of your own healthcare, and I think you phrased it perfectly. Be an advocate for your own first test. That's very well said. I'm just going to go around the horn, and please, each of you take a minute and either give your best take-home tip or your best summary comment to the audience. And I'll start with you, Brother Figueroa Mosley.
Yes, I wanted to talk about that. We die because of the lack of knowledge, and I think we, in addition to having the knowledge base in terms of screening for prostate cancer, that we be our own advocate, and if we can't be an advocate for ourselves, have someone like a family member, a wife, cousin, brother, be an advocate for you. And most of all, if you have increased risk factors for prostate cancer, get screened early. And if you don't, then be sure to screen between 40 and 45 years of age.
Thank you very much. Let's go back over to Brother Dr. Letzum.
Two things I've learned over a couple of years, and it doesn't always sound pleasant, but aging doesn't just magically happen, and aging is not for the weak. And I say that to encourage brothers who might be feeling like, wow, this is a lot. It is. We don't want to downplay it that it's nothing. But just like every big thing in life, buying a house, getting a degree, fixing a car, raising children, if you put in the work, do the steps, do the monitoring, it's going to work out. And that's what we want to encourage you to do. Take a vested interest in your health, your well-being, so that you can be around not only for the House of Alpha, but for your own household.
Thank you. And we'll move over to Brother Deputy Surgeon General Narcisse.
Yes. As a physician who specializes in taking care of older individuals, older men, I would like to say that aging is a blessing that not everyone has an opportunity to enjoy. Screening for prostate cancer is something that can be done and is helpful. And since we started screening, we have reduced mortality of prostate cancer. So get it done, be your own advocate, and don't take no for an answer.
Fantastic. And we'll move over to Colonel Brother Williams.
Well, we're talking about aging, and I just celebrated my 85th birthday on the 28th of August, a couple of days ago. And you know, it's weird being the same age as old people. And so it is important, and it's so devastating to me, especially looking at the African American community, of the brothers out there who work hard, save their money, educate their children, retire and die. And they die because of the health behaviors that we had talked about today and the things that they should do, they shouldn't do. We need you. America needs you. Your family needs you. And you should get a good return on your hard work and your investment in this country. And you do this by taking care of your health, and improving and having a good quality of life in your later years. And so I'm glad you are on board with us this evening, and will stay with us as we continue to talk about health.
And we want to now move to Deputy Surgeon General Womack. Thank you for an outstanding moderation of this panel. Let's hear your final thoughts.
Now, thank you very much to the panel. And, you know, I can go into a lot more deeper details, but one thing I want to leave everyone with, and I've been a researcher and I've talked to men about prostate cancer screening. I've gone out to the streets, to the basketball courts, to the AAU tournaments, to anything, to talk to men and get pamphlets out. And one thing is consistent in a message I try to get across: you matter. Everyone you touch, everyone you see, your family, and denying them your presence based upon something that you have the opportunity to take care of is a crime in itself. And you have to be in their lives. So you matter. So I know with COVID, it's been tough with a lot of things. Make sure you're making your yearly physical exams to go get checked, to ask questions, be a part of your healthcare. So again, you matter. And that's why we are here to have this discussion with you, because we believe you matter, as well as we believe that we matter as well.
But thank you all. We have two programming notes. We will come back on September 30th to continue a cancer on prostate cancer awareness with a focus on treatment. So come back for that. And next Thursday, we actually will be joined by the Family Health Subcommittee of the Surgeon General Initiative of Alpha Phi Alpha to talk about healthy aging. That's right. We're going to try to get into the fountain of youth and talk about things that you can and should be doing to allow you to have both a long and healthy life as you age. So thank you very much for participating. Thanks again to all of our panelists. I hope that you are doing well out there, and thank you for participating. We'll see you same time next week, 7 p.m. Eastern, for the Alpha Phi Alpha Surgeon General Initiative webinars. Have a great evening, everyone.